you can take over.
Yeah, I think we can save the time. Thank you very much for the kind introduction. And at the outset, I thank Dr. Bansi Sabu and scientific team of Diabetes India for inviting me for this beautiful venue, beautiful conference. Dear friends, Dr. Manisha has given you overview of the diabetic kidney disease, the pathophysiology, and the real management, how to manage the diabetic kidney disease. But why the diabetic kidney disease occurs in a patient of diabetes? We started our studies around 25 years back, and we started doing the RAS genes initially, and we found two RAS genes with the All Indian Institute of Medical Sciences, Bengaluru and Jaipur. And these two, what we found that the person who harbors these two genes, two RAS genes, they have the aggravation of the one of the cytokine, inflammatory cytokine, TGF beta 1. And this TGF beta 1 ultimately increases so many chemokines. And then we also published all these chemokines and how these chemokines ultimately lead to the microRNA, and that is going to the mitochondria, which Dr. Krishna Seshadri told just now. So what we found that is a chain of events when you have harboring the RAS genes, and then you go into the aggravation of the cytokines, inflammatory cytokines and chemokines, and ultimately lead to the faulty microRNAs and the faulty proteins, and ultimately you have the microalbumin leak in the urine, and that is the first sign of diabetic kidney disease. And then Stanford have taken this study and they started doing the PKC beta inhibitors at that time, 20 years back, but unfortunately they did not work. PKC beta inhibitors for preventing the diabetic kidney disease. So now we have got the two beautiful agents. There are other agents also, but SGLT2 inhibitors, as Dr. Manisha has told, and the GLP-1 receptor agonist, these are the two molecules have the best cardiorenal benefits till date. These are my disclosures. So, dear friends, just we know that diabetes kidney disease is actually a progressive disease, and actually it starts much before the things. And she has already given you the all the overview how the diabetes causes the diabetic kidney disease, and the management. She beautifully told that it starts from the lifestyle modification, dietary modification, and especially she is very particular, and I am also particular that Indians are already having the protein deficiency. 60 to 70% Indians publish studies that have the protein deficiency. Please do not ask our patients still further have the protein deficiency. We still need, I think, around 20 grams of protein, 0.8 milligram per kilogram body weight, even in diabetes patients. So please do not restrict too much of protein in our patients. They are already having the protein deficiency. And then we have the tier 2. She has already given the beautiful RAS blockades and the SGLT2 inhibitors, statin, and all sorts of the treatment she has already been alluded to. So now let us talk about some of the, the kidney outcome trials, which I'll be giving you the contemporary treatment paradigms. And these trials are actually I have selected not all the trials, but few selected trials, which is very, very important and which gives us the confidence of using the SGLT2 inhibitors and GLP-1 receptor agonists in the management of diabetic kidney disease. So I'll start with some of the trials with the sodium glucose transporters inhibitors, mineralocorticoid receptor agonists, and the GLP-1 receptor agonists. So let us start with the very important trial, the known as Credence trial. And what was the Credence trial? It is the canagliflozin use versus placebo. And this is basically all the patients of type 2 diabetes patients were taken, and all those patients were taken who have the diabetic kidney disease, and that was treated with RAS blockade. That was the Credence patients inclusion criteria. And this group had a very lower risk of kidney disease progression or cardiovascular events than the placebo group. So this is the inclusion criteria of the patients. So the what is the primary composite renal and mortality outcomes. If you see here, if you I think if you can see here, this is a primary composite outcome, and it beautifully says that it is much better. Canagliflozin is much better than the placebo as far as the primary outcome composite outcome is concerned. And if you see here, the end stage renal disease here, again, at any point of time, whether it is a primary or it is a renal outcome or it is the end stage renal disease, all here, if you see here, the canagliflozin was much better as compared to the placebo in all the patients of DKD patients here. And if you see the subgroup analysis here, again, if you subgroup analysis, this is all shift to left here, and whether it's a primary composite outcomes of end-stage renal disease, or it is a doubling of the serum creatinine, or the on the cardiovascular outcomes, the all are here. They are on the shift to left. That means canagliflozin is better than the placebo in the all the patients with the diabetes kidney disease. And now two major effects have been shown here, effects on UACR, urinary albumin creatinine ratio, and change from baseline in the estimated GFR. So as far as the UACR is concerned, if you see here, this is a canagliflozin, this is the placebo here, and much better effect, and this is sustained effect. Not only that, it is a sustained effect of the canagliflozin on the reduction in the this USCR here. And as far as the change from baseline in the estimated GFR, initially there is a little bit gap, but later on canagliflozin is better as far as the estimated EGFR effect on EGFR is concerned. So dear friends, if I can summarize the credence trial here, canagliflozin significantly reduces the risk of major cardiovascular event, one thing, cardiovascular deaths, non-fatal myocardial infarction and non-fatal strokes were consistently reduced. So this is for the sort of first time we have shown that any SGLT2 or any molecule has shown the effect on the cardiovascular outcomes. As far as renal outcomes are concerned, both renal and cardiovascular death or hospitalization for heart failure were also favorably impacted here. And if you see here, the p-value is less than 0.05 here. Now, another very important trial is the DAPA CKD trial. And what is DAPA CKD trial? These are in this trial, the patients were taken on the dapagliflozin as compared to the as compared to the placebo, and they are all patients with the CKD here. It is a sustained decline what in the estimated GFR of at least 50% here in DAPA CKD, and stage kidney disease and death from renal or cardiovascular outcome causes was less frequently with the dapagliflozin. And if you again see whether it's a primary outcome here or it is the deaths here, dapagliflozin have shown much better effect. I'm not going detail of the data and don't want to give you the jargon of data here, but the gist of the clinical trials here, and the DAPA CKD has clearly shown here again as compared to placebo, DAPA is much better and change from baseline EGFR is concerned. So DAPA around 10 milligram per day was tested in patient with CKD here. The primary endpoint was a composite of more than 50% EGFR decline, and the trial was aimed at 90% power to detect a 22% related risk, and it is a positive trial. Another is a Fidelio DKD trial. It is a mineralocorticoid receptor agonist trial, and it is a finerenone versus placebo. And again, the patients of type 2 diabetes with CKD. Here, treatment with the Finrenone resulted in the lower risk of chronic kidney disease outcomes and cardiovascular. And these actually clinical trials gives us the real confidence of using these molecules into the day-to-day practice. And that's why these clinical, we have to learn all these clinical trials. Again, as far as the primary outcome, composite outcomes are concerned, if you see here, this is a placebo, this is a Finrenone, and if you see here, uh, whether it is a kidney failure, whether it is a sustained decrease in the EGFR from the baseline and secondary composite outcomes, all have shown the clear benefit of using the Finrenone as compared to placebo. Efficacy outcomes are concerned, if you see here, whether it is a kidney failure is concerned, whether the ESRD or whether it is a sustained reduction in the EGFR is concerned. If you see here again, there is a shift of left. So all primary and secondary outcomes have shown the beneficial effect of Finrenone in the type 2 diabetes patients or DKD patients. And as far as the effect on albuminuria or the serum potassium, you have asked about the potassium here, and this is very, very important. Whenever we are using any MRAs, again, whether the SGLT2 inhibitors or whether we are using the MRAs, serum potassium we have to monitor on a very regular basis. That is the very important aspect whenever we are using MRAs or SGLT2 inhibitors here. And if you see here, effect on albuminuria, UACR on the potassiums over the time, I think there is no much difference when you are using the MRAs or Finrenone here, but as far as the albuminuria is concerned, it is much better. So dear friends, Finrenone has shown the reduction in the composite cardiovascular outcomes, whether it's a mortality by cardiovascular deaths or MI, stroke, or heart failure hospitalization is concerned in CKD and type 2 diabetes, regardless of heart failure study. That is important thing here. The next one, again, a Figueroa trial. This is again Finrenone versus placebo, and important aspect of here is the patients with the stage 1 to stage 4 CKD have taken into this study. And of course, this study have shown the Finrenone treatment was superior as compared to placebo with regard to the primary outcome, primary composite outcomes are concerned. All primary outcome, whether the death from cardiovascular causes, non-fatal myocardial infarction or non-fatal stroke or hospitalization for heart failure is concerned. If you see here, cardiovascular outcomes are actually much favorable in the Finrenone in the Figueroa DKD trial. Efficacy outcomes are concerned, again, except here it is midline, otherwise all shift to left here, and this primary and secondary outcomes are definitely in favor of Finrenone here. And as far as mortality is concerned, if you see, Finrenone has the less 12.4 as compared to 14 in the placebo. So mortality is less, hospitalization for heart failure again is lesser in the Finrenone group as compared to the placebo group. So it has shown the trend towards the kidney protection. First time this Finrenone in this clinical trial have shown, and what we have seen here, the significantly reduced more than 57% EGFR decline. Very significant here in this Figueroa trial here. And the benefits were greater in the patients with severely increased. So more DKD is there, more advanced stage is there. The effect is have been shown here is better in this clinical trial. I'll not give. Dr. JJ has warned me not to talk about the EMPA kidney because he will give you all the details about the EMPA kidney. So I'll skip this clinical trial for the benefit of, because he will take you in the details of EMPA kidney trial, and this is very important landmark trial at present. Of course, it resulted in a lower risk of disease, so I'll not go into the details of EMPA kidney. Canvas trial, again, very important clinical trial. It is a canagliflozin versus placebo. It reports of two randomized trials, patients with type 2 diabetes or at risk of cardiovascular disease received and were followed for 188 weeks. So this result has clearly shown here that it reduced the risk of cardiovascular events, whether it's the body weight is concerned. Again, the very important thing with the SGLT2 inhibitors, as Dr. Manisha has told, not only this glycemic control, but also reduction in the body weight and also in the blood pressure. So from all point of view, if you see here, whether the glycated hemoglobin is concerned, whether the body weight is concerned, systolic blood pressure is concerned. So from all point of view, if you see here, the canagliflozin has shown the beneficial effect. Cardiovascular outcomes are concerned, as far as that thing. Again, the death from the cardiovascular causes, cana is better. From the cerebrovascular causes, again stroke, not much different, but little bit better in the, as far as the stroke is concerned. And non-fatal myocardial infarction, all these things except either the non-fatal stroke, probably we don't know. This is a little bit of controversial here as far as the stroke is concerned here. So as far as major outcomes are concerned, cana has shown much better outcomes. So it reduces the risk of kidney disease progression and slows the eGFR decline, of course, and the mean UACR was around 80% lower with cana gliflozin, and the renal related adverse outcomes were similar between two groups. So I mean, this has shown a little benefit of canagliflozin. Another trial, it is a leader trial. This is the GLP-1 receptor agonist, liraglutide versus placebo. And again, this is a leader trial. Leader studies have shown for the first time that GLP-1 receptor agonists are also have the cardiovascular benefits as well as the renal outcome benefits. And the rate of the first occurrence of cardiovascular death, non-fatal myocardial infarction, non-fatal stroke was lower with liraglutide. And if you see both, whether it's a primary and exploratory outcomes are concerned, this liraglutide for the first time has shown the benefits here. And if you see, this is in the varied of the demographic groups. It is not restricted to a particular group of patients, but wide demographic patients. If you see here, the effect has shown, consistent effect has shown of the liraglutide. So again, all-cause mortality was lower. The incidence of non-fatal myocardial infarction, stroke, and heart failure hospitalization was lower, but statistically, it is not significant. Here in this, especially the leader, this trial, I have not gone into the different leader trials because of the shortage of time. Rewind trial, again, very important. This is again dulaglutide versus placebo, and subcutaneous administration of dulaglutide was given in patients of type 2 diabetes who had either a previous cardiovascular event or cardiovascular risk factors. And again, if you see the cumulative incidence of cardiovascular outcomes are concerned, composite cardiovascular outcome, cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke, except the non-fatal myocardial infarction, this dulaglutide has shown a beneficial effect here. So subgroup analysis again, as far as the age is concerned, all age groups, duration of diabetes, all duration of diabetes from 5, 10, 20 years, and the other parameters. Again, if you see here, it is a beneficial effect. So all groups, it is not restricted to a single group, and continuous measures during the follow-up, it has shown the beneficial effect. So dear friends, these are my last one. So there is a new evidence of kidney and cardiovascular protection. SGLT2 inhibitors and GLP-1 receptor. Huge cardio-renal benefits. I think it is a must to give GLP-1 receptor agonists and SGLT2 inhibitors in most of the kidney disease patient. And as Dr. Manisha has told us at the last yesterday, that we can use SGLT2 inhibitors even up to less than EGFR, less than 20 EGFR. And I think you are saying that we can give up to the patient going into the dialysis. But as far as this, the efficacy of SGLT2 inhibitors have reduced. Otherwise, we can use the SGLT2 inhibitors. So flow trial and select trial, I'll not go into the again detail because this is a very new important trial. She has already given you the details of flow trial, and this is actually after a planned interim trial that indicated a significant benefit, shows huge benefit. The trial was stopped early, prematurely stopped, with a median follow-up around 3.4 years. An interim trial has reported 24% primary end outcome, 21% reduction in kidney specific endpoint, 18% first major cerebrovascular event, and 20% all cause mortality. That's why this trial was prematurely stopped. And again, in the select trial, if you see here, after a mean follow of around 39 months around or 40 months, 20% lower risk of cerebrovascular events were observed with semaglutide. So we have these are the new clinical trials, and of course we have a first clear evidence of kidney and CV protection with this flow trial, and first evidence have shown in the select trial the kidney protection which facilitate the weight loss, and a strong rationale for further studies. Of course, we need that. Why they are so beneficial in weight loss as well as for the renal outcome benefits. So thank you. These are the 4 pillars she has already told. The metabolic control of diabetes is needed. Then we need the drugs, SGLT2 inhibitors. We need the RAS blockers, antihypertensives, and ultimately we also need some of the in the metabolic acidosis and acute cases the management. So thank you very much for patience listening.